ECG is a graphical recording of the conduction of the heart and is the average of all the cells in a certain position. So on a graphical record, there would be a wave, and everything above the baseline is a positive deflection, and everything below is considered a negative deflection. The deflections are in relation to the heart and its electrical activity, and can be explained in this way. Depolarization towards the positive electrode produces a positive deflection, and depolarization away from the positive electrode produces a negative deflection. In order to get an ECG wave, we need a negative and a positive electrode. So when we look at the conduction system, the signal is first sent out from the SA node, but it's not in the singular direction. What the ECG records is an average vector. So we have depolarized conduction that is going from the SA node to the AV node towards the positive pole, causing a positive deflection known as the P wave. The AV node then delays conduction by slowly depolarizing within itself, meaning there's a very minimal movement of signal, and this would give us a flat line. This flat line is known as the PR interval and is essentially where the AV node is slowly conducting action potentials. From then, the AV node first signals the left bundle branch, which then activates the septum and then the right branch. So when we look at this closer, the left bundle branch's septal activation's average vector goes in a direction that is not towards the positive pole. And as we said earlier, depolarization away from the positive pole would generate a negative deflection. So this minor negative deflection is known as the Q wave. The depolarization continues down the bundle branches, inducing action potentials towards the Purkinje fibers. The signal goes in all directions, but remember, the left ventricle is thicker than the right, so majority vector would be towards the left pole, causing a huge positive deflection. And this positive deflection is the R wave. Once the bases of the ventricles are depolarized, the signal moves towards the outer and the superior parts of the ventricles, and in terms of direction, it moves away from the pole, and this, as you guessed, would give us a negative deflection. Once the entire ventricles are depolarized, there's a momentary recording of no electrical activity and no deflection. Remember, during the ST segment, the ventricles are still depolarized. Now I want to pause here and stress on a key point. So far we have discussed the deflections during depolarization. The deflections behave in an opposite manner when it's repolarized. So repolarization towards the positive pole would give a negative deflection, and repolarization away from the positive pole will give a positive deflection. And I'm explaining this concept as the ventricles repolarize, the net vector's direction is away from the positive pole, and that's why the T wave is of a positive deflection. So as a quick summary, the P wave is indicative of the atrial depolarization, essentially the signal from the SA to the AV node. The PR interval, a flat line, is indicative of the AV depolarization by itself. The Q wave is a negative deflection, indicating the septal activation. The QRS complex indicates ventricular depolarization, and the T wave gives a positive deflection for ventricular repolarization. The ECG is used to see if there's any abnormality in conduction. But what if we wanted to know where exactly in the heart is a defect? And that's how ECG leads come into the scene. Leads are basically an electrode or a pair of electrodes placed on a person, and it gives us a window to view the heart in different angles. There are 3 types, and I'll go through them one by one. Bipolar leads, bi meaning 2 poles. There is a negative and a positive electrode, and the actual record is the difference between these 2 points. So before we start, we need to know the Kirchoff's law, which says that a sum of a closed loop is 0. A man named Einthoven decided to make a closed loop circuit around the heart. 3 bipolar leads were placed with 2 electrodes at 2 different points. So he put a negative pole on the right arm and a positive pole on the left arm. Remember, the cardiac conduction went almost in the same direction. This placement, known as lead 1, gave Einthoven a positive deflection. He then put a negative pole on the left arm and a positive pole on the left leg. This lead 3 also gave him a positive deflection. When he did the same on the other side with lead 2, a negative pole on the left leg and a positive pole on the right arm, because the signal was going opposite to the heart's conduction path, it produced a negative deflection. Now this negative deflection on lead 2 would not follow Kirchoff's law, and so he flipped it. So for lead 2, it had a negative pole on the right arm and a positive pole on the left arm, and this was essentially parallel to the conduction pathway of the heart, and it gave a positive deflection. From Kirchoff's law, the sum of the closed loop, which is lead 1 plus lead 3 plus a negative lead 2 as it's a vector, would be 0. And if you rearrange it, then the sum of lead 1 and lead 3 would give you lead 2. And this equation was known as Einthoven's law. He also states that lead 2 will give the greatest positive deflection as it's the sum of two leads, and it makes sense as it runs exactly parallel to the heart's conduction system. So how do these bipolar leads give us a window into the heart structure? As a rule of thumb, the view is perceived from the positive electrode. So leads 2 and 3 have the positive electrode both at the left leg. So if you look from that angle, you would get an inferior view. Lead 1 is positive on the left side, so the view from the heart from the left angle will give you a left lateral view. So moving on to the next type of leads, the unipolar leads. Bipolar lead uses a single positive and a single negative electrode. The unipolar leads were created with a slightly different purpose. Each positive electrode provides a singular view, and in that sense we have three different views from the unipolar leads. If the right arm has a positive electrode, then the other 2 points are poled negatively. The single positive electrode is measured against the combination of the remaining negative electrodes. Like we said earlier, we perceive the view from the positive electrode. In this, we get an augmented view from the right side, written as AVR. When the left arm gets a positive pole, the remaining 2 have a negative pole, and the augmented view goes towards the heart from the left, resulting in the augmented view from the left known as AVL. And lastly, when the left leg has a positive pole, the remaining 2 have a negative pole, and the augmented view is from the foot, AVF. The overall window from this is that the AVF gives us an inferior view, the AVL gives us a lateral left view, and the AVR gives us a lateral right view. Combining the bipolar leads and the unipolar leads, we get various angles of the heart in the frontal plane. So to assess the heart's inferior portions, you look at leads 2, leads 3, and AVF. To assess the lateral left, you use leads 1 and AVL. The final set of leads used to measure the ECG are the chest leads. These are the leads V1 through V6. Unlike the other leads, these give a transverse view, a sort of cross-sectional slice into the heart. So this is in accordance with how the leads are placed. V3 and V4 record primarily the septal activity. V1 and V2 measure the anterior, V5 and V6 measure the lateral activity. If you want to measure the posterior wall's activity, you could place V7, V8, and V9 leads, and they're placed on the back of the patient, although this isn't routinely done. So to wrap up all the leads and its significance, V6, V5, AVL, and lead 1 give you a lateral view. V1 and V2 gives an anterior view. V3 and V4 record septal activity, and leads 2, 3, and AVF give an inferior view. So the next time you look at an ECG strip and recognize abnormalities, try to remember which leads represent which areas, and that can tip you off into the location and even a differential on the diagnosis.